Hi, my name is Dr. Michael Bottros, and I am the Clinical Operations Chief and Medical Director for Pain Services at the Keck School of Medicine in Los Angeles, California, at the University of Southern California. I'll be presenting to you today the long COVID syndrome and its implications for anesthesiologists in the perioperative period. I have nothing to disclose. We'll be talking about the pathophysiology, as well as the first half of this talk being about acute COVID in terms of its clinical features, its treatment, and then the second half of the talk is about long COVID, as well as its issues with organ dysfunction, how we treat long COVID currently, and its implications in the perioperative period, and we'll conclude. First, we're going to begin with pathophysiology. The SARS-CoV-2 targets cells through a spike protein, designated here as S, that binds to the angiotensin-converting enzyme receptor. The serine protease type 2 transmembrane serine protease, which we're going to term TMPRSS2, promotes the viral uptake by cleaving that ACE2 and activating the protein. In the early stage, viral numbers can be very high, especially in the lower respiratory tract. And what happens is there's an inflammatory cascade of signaling molecules that occurs through recruited T cell lymphocytes, monocytes, and neutrophils. And that's what produces that inflammatory response. So in the later stages, pulmonary edema develops, especially in the alveolar spaces, and hyaline membrane formation, which in the early phase of acute respiratory distress syndrome may be very similar, at least clinically. Now, I want to point out some interesting new material because in addition to what we just talked about, there is more and more information about how this virus attaches to cells. And it turns out that there is a recent study that you see the citation here for, that turns out that the SARS-CoV-2 infection actually can target adipose tissue, fat cells, specifically mature adipocytes and adipose tissue macrophages. And that even though pre-adipocytes might not be infected, they can even adopt a pro-inflammatory phenotype. So everything is producing massive inflammation. And they were able to find this by finding RNA of the virus in adipocytes in autopsy cases of patients infected with COVID-19. And so that's why it may explain the link between the high risk of patients who are obese and the patients who developed COVID-19 due to this adipose tissue infection. Here you can see that they had staining for the SARS-CoV-2 RNA in adipose tissue. So in A and C, this is a section of heart tissue, and then in B and D, you can find that it is magnified, representing the region of RNA from the virus. In the lower portion here in E, you'll find epicardial fat and myocardium in the red, and you'll notice that there are a number of blue arrows that show RNA from the virus in epicardial fat. Moving on to the clinical features of acute COVID. In order for us to understand long COVID, we need to have a better understanding of acute COVID. And of course, as you know, the acute features of COVID have different manifestations based off of age. So people who are young, less than 50 years of age, or even less than 10 years of age, may be asymptomatic during the incubation period, may develop only mild disease, which is about 81% of patients. That includes things like fever, fatigue, dry cough, maybe even some pneumonia. However, in older patients greater than 60 years of age, they may develop severe symptoms like dyspnea, shortness of breath. They may need to be watched in the ICU. And then in people who are even older, such as greater than 68 years of age, they may develop acute respiratory distress syndrome symptoms, as we talked about earlier, even acute cardiac injury and multi-organ failure. I would be remiss if I didn't mention multi-system inflammatory syndrome in children. So this was something that, as you can see, started being noticed in the spring of 2020. As more and more adults and children started getting infections with COVID, we started noticing, as you can see in the red, an increase in this multi-system inflammatory syndrome, MISC. You can see here that the development of COVID in children is quite different than what we see in adults. In this study looking at 662 children, you'll find that the majority of these kids have fever and they have abdominal pain and diarrhea. It affects the GI tract much more than the respiratory tract. As you can see, only 18.3% of children had dyspnea or shortness of breath. The majority of kids develop diarrhea and maybe even vomiting. They also can develop symptoms of conjunctivitis and cheilitis, and also rash. So given the preponderance of those types of symptoms, you can see that it is very similar to how Kawasaki disease is presented in kids. And that's what brought people to a further understanding of this syndrome called multi-system inflammatory syndrome in children. Back to adults. What are the risk factors for developing acute COVID? Older age, male sex, non-white ethnicity, if people have pre-existing disabilities or comorbidities. We talked about obesity earlier, but also people who have cardiovascular disease, respiratory disease, or hypertension. Now, how do we treat acute COVID? Well, the first step is supportive care and respiratory support. So this was more true earlier in the infection when we didn't have vaccination or resistance. And so more and more people needed respiratory support. More than 75% of patients hospitalized with COVID-19 required supplemental oxygen therapy. And if it was not enough, they would get heated high-flow nasal cannula oxygen. And if they needed mechanical ventilation, we used a protective ventilation strategy. So low tidal volumes, 4 to 8 milliliters per kilogram predicted body weight, and keep the plateau pressure less than 30 millimeters mercury. Now, the threshold to intubate is controversial. And you can see that this is emerging literature and things are changing as we learn more and more about the virus. Early on in the COVID-19 infection paradigm, earlier intubation was favored because it allowed for a more controlled intubation process, because there was a lot of logistical challenges, making sure that patients were isolated, they were in an airborne isolation room, that the intubating physician or provider had to don the appropriate personal protective equipment. But what we're learning is hypoxemia in the absence of respiratory distress is actually very well tolerated, and that patients can do very well without mechanical ventilation. And that it turns out earlier intubation thresholds may have resulted in some patients unnecessarily getting mechanical ventilation and then therefore predisposing to additional complications. In this study, we saw over 8,000 patients, close to 9,000 patients in 12 studies, looking at no statistically detectable difference in all-cause mortality between patients who were earlier intubated versus late intubation. So it turns out that the timing of intubation may actually have no effect on mortality and morbidity in critically ill patients. That's why this may justify that wait-and-see approach leading to fewer and fewer intubations. And that's what we're seeing now, especially as more and more people are having vaccines and are developing some resistance. So therefore, the guidelines have to be updated. The following classes of drugs are being evaluated or developed for the management of COVID-19. As you know, there are antivirals like remdesivir, there are antibodies like convalescent plasma, anti-inflammatory agents like steroids, dexamethasone, and even statins. There's targeted immunomodulatory therapies like the tocilizumab and the sarilumab, anticoagulants like heparin because of the risk associated with blood clots, and of course, antifibrotics for the same reason. This is a summary slide of all the different SARS-CoV-2 targets regarding the medications that we use in acute COVID. And you can see that it is trying to target everywhere from attachment to the cell, all the way through replication, all the way through the inflammatory cascade that you can see. So it's likely that different treatment modalities have different efficacies based on the different stages of the illness. That's why we want to give antivirals early on in the infection, not later on. Otherwise, it won't be very supportive or helpful. And then in hospitalized patients, we may want to use immunomodulatory agents to prevent disease progression. And then, of course, the anticoagulation medications to prevent thromboembolic complications. Moving on now to long COVID, we have to discuss what the true definition of long COVID is before we can even start discussing it. Acute COVID usually lasts from beginning of symptoms till about 4 weeks from the onset of symptoms. Because competent SARS-CoV-2 can be isolated up until that period of time. Post-acute COVID-19 is defined as symptoms that persist or long-term complications that can occur 4 weeks from the onset of symptoms. So as you can see here in this publication from the UK National Institute for Healthcare and Excellence Guidelines, the NICE guidelines, you can see that the active infection is from 0 to 4 weeks, post-acute COVID-19 4 to 12 weeks, post-COVID-19 is 12 weeks and later. And that's where we have the associated ACE2 associated symptom damage. Now, what are the risk factors for developing long COVID? Age. People who are greater than 50 years of age have the greatest odds ratio. Also, a number of pre-existing medical conditions have been associated with a higher rate of not returning to usual health. That includes hypertension, obesity, a psychiatric condition, and an immunosuppressive condition. Now, these risk factors are actually slightly different in the development of long COVID than the risk factors associated in the development of acute COVID. Here's the reason why. As you can see, patients with more severe acute COVID are at higher risk of developing long COVID. So people who have more than 5 symptoms during the initial COVID infection are at a higher risk of developing long COVID symptoms. But the thing is that some factors associated with COVID-19 do not increase for long COVID. For example, long COVID symptoms are higher in women compared to men, which is different than the acute COVID symptoms. And also, the age group that's most affected by long COVID are actually younger patients, not the older patients. So people who are older than 70 years have only had this effect in general about 18%, whereas closer to 27% of people aged 35 to 49 years have an affected symptomatology. What happens in long COVID as it affects different organ systems? Well, we're going to approach this from a top-down approach, similar to how we do when we round on patients in the ICU. We're going to start with the respiratory system, and we notice that, as we discussed earlier, many patients develop symptoms very similar to ARDS, acute respiratory distress syndrome. We see this because there are a number of bilateral diffuse alveolar damage, there's fibromyxoid exudates, desquamation of pneumocytes. We know this because of how it binds to the ACE2 receptor, like we talked about earlier, and it causes that post-ARDS fibrosis. So people can still have pulmonary function deficits even 6 months after the infection with diffuse impairment and long-term in situ thrombosis. This is very important as an anesthesiologist to understand the risks associated with intubation and ventilator management. You can see that in this study, they looked at patients in 3 categories. You can see that there are a number of patients on the left that had no oxygen, just oxygen alone. Patients in the middle had CPAP treatment, and then patients on the right had invasive ventilation, mechanical ventilation. And you can see the difference in symptom persistence between the 3 groups. So patients who had fatigue continue to have fatigue in higher preponderance in patients who had more and more invasive mechanical ventilation strategies. People continue to have poor sleep quality, cough, and breathlessness, and they're looking at this up to 100 days post-discharge from the hospital. In terms of image findings, because if you're going to work patients up prior to their surgery, you may find a number of different things, but you need to keep in mind the limitations of each. Chest X-ray does not correlate with abnormal CT findings or functional disability in infected patients, because there's always a lag with chest X-rays. So changes in chest X-ray findings are associated with recovery duration and severity of the COVID-19, but the effectiveness of getting a chest X-ray pre-op is uncertain. What may be more beneficial is a CT scan. Abnormal CT findings were detected in 71% of COVID-19 survivors. There's still unresolved lung tissue pathology and a significant correlation with disease severity. You may also consider a lung ultrasound, because lung ultrasounds correlate with chest CT, and you can also correlate with the potential for doing this in the home setting. MRI is interesting because you could also assess cardiac involvement. 58% of recovered patients had abnormal MRI findings, including 54% of patients had myocardial edema and late gadolinium enhancement in 31% of patients. Fibrosis and a compromised right ventricle, because of what's going on in the lung, have been found in patients who have recovered from COVID-19. Now, moving on to the next category, the cardiac system. There's endothelitis, there's microthrombosis, hypercoagulability, atrial fibrillation, SVT has been seen in these patients. And this is because of capillary disturbance and impaired oxygen diffusion with an increased target to blood pool ratio. We think that this is going on because of cytokine storm, that inflammatory cascade that we talked about. It's causing endothelial dysfunction. 81% of COVID-19 myocarditis patients survived the acute episode, but there is ongoing subclinical myocarditis that could lead to myocardial dysfunction and even sudden cardiac death. From a hematological system, patients are at high risk for developing thromboembolic events. We see elevated convalescent D-dimer and C-reactive protein levels, increased biomarkers of inflammation. And that's why we need to know whether or not we should continue monitoring these biomarkers to determine if the risks are still continuing to be associated long-term. The urinary system has shown acute kidney injury and a declined GFR because of the high abundance of ACE2 expression in kidneys, because of where these viruses target. So there's a significant risk of morbidity and mortality. The GI system has been shown to have hepatic and cholecystatic liver injury and pancreatic injury with diffuse bowel damage. We see enterocyte desquamation. We see edema, especially small bowel dilatation, as well as mesenteric node hemorrhage and necrosis. Again, there's a lot of ACE2 receptors and furin expressed in the GI tract. There have been reports of fecal oral transmission of this virus. And liver enzymes actually remain persistently elevated 14 days after discharge, with a liver function in the majority of patients do normalize about 2 months after hospital discharge. What's very interesting is what happens to the endocrine system, because we're seeing hyperglycemia without diabetes mellitus. New onset diabetic mellitus in patients who have had COVID-19, because it is destroying pancreatic beta islet cells. It's triggering an autoimmune response from the exposure of the antigen from damaged islet cells. So we're seeing more and more newly diagnosed, almost what we would call type 1 diabetics as a result of acute COVID developing into this long COVID syndrome. Neurologically, we see mood changes, cognitive difficulties, fatigue, headache. It may be due to hypoxic injury from microbleeds, as well as neuronal inflammation. The mechanisms, as we might have discussed earlier, blood vessel damage, impaired oxygen supply. We also have cytokine-mediated cellular damage, inflammation going on from T cells, and it's very similar to strokes and neuroinflammatory diseases. Over 40% of survivors without prior psychiatric conditions lived with depression within 90 days from the recovery of COVID-19, and 70% of them don't receive treatment or for depression. This is a summary slide that you can refer to that summarizes all the different organ systems we discussed regarding the long COVID syndrome. 1 year out from COVID-19, in this study from China, we find continued problems. They looked at 6-month and 12-month post-discharge visits, and they used different questionnaires, including health-related quality of life, physical examination, a 6-minute walking test, and then a number of laboratory tests. They used non-COVID-19 controls. They were matched for age, sex, and comorbidities, and they did the same sort of outcomes. The primary outcomes were the symptoms, the modified British Medical Research Council score, quality of life, and distance walked. And you can see in this busy slide, but I'm going to focus on a couple of things. At 12 months after infection, almost half of the patients still have at least one of the following symptoms. And the big ones are fatigue or muscle weakness in 20% of people 1 year out. Sleep difficulties continue, hair loss, and then joint pain. They still have these issues. And you can see that pain or discomfort 1 year after the acute COVID infection continue to be a problem in as much as almost 1/3 of patients. And almost 1/4 of patients, or I should say over 1/4 of patients, continue to have anxiety or depression. What's interesting is they checked inflammatory levels of different cytokines at the acute phase, and then when they were discharged from the hospital, and then at 6 months and 12 months, and you can still see persistent inflammation. That's very important. You can see that there's inflammatory cascade markers that are still present via IL-1 beta, IL-6, TNF alpha. These are all the types of cytokines that have been associated with persistent pain syndromes. So how do we treat long COVID? Well, we are using the UK NICE guidelines, which are using a questionnaire and then a combination of laboratory tests and blood tests. Now, for mild symptoms, you can just do some home surveillance or telemedicine. Moderate symptoms, they need to be seen with regular follow-up and have some community therapy team. If you have severe symptoms, we might need a multidisciplinary team with regular follow-up. So what do we mean by a multidisciplinary team? Well, there's usually a primary care provider that makes sure they consider early rehabilitation and patient education. There may be a renal physician because of the associated problems that we talked about. Hematology is needed to ensure appropriate thromboprophylaxis for high-risk survivors. People who have issues with anxiety and depression may want to see a psychiatrist or a neurologist because of the disturbances and cognitive impairment. And then, of course, cardiac or pulmonary physicians because of the associated symptomatology. Now, what are some of the treatment options? Well, there are some non-pharmacological strategies for shortness of breath, breathing exercises, pulmonary rehab, maintaining optimal body positioning for postural relief, and in fact, antifibrotic therapies may be advantageous. Cardiac treatment involved potential beta blockers for cardiac complaints, including angina or cardiac arrhythmias. So therefore, beta blockers may be useful in treating some of the long-term manifestations of long COVID-19. Myocarditis usually resolves naturally over time, but we may need to use immunomodulating therapy to improve recovery. A review has also suggested that anticoagulants can help reduce the risk of hypercoagulability. Cognitively, people describe brain fog or things similar to chemobrain, and the Mayo Clinic recommends a number of non-pharmacological approaches like memory repeating exercises, tracking what influences the deficits, stress relief coping strategies. Medication-wise, things like methylphenidate, donepezil, modafinil, memantine may be considered. And then, interestingly, a natural flavonoid, luteolin, may alleviate cognitive impairment because it inhibits mast cell and microglial activation, but we still need more clinical trials. Now, antihistamines have been implicated as a possible treatment as well. A study suggested that H1 antagonists may be able to reduce COVID-19 infection rate by inhibiting SARS-CoV-2 from entering the ACE2 expressing cells. It remains whether or not antihistamines have the potential for treating long COVID-19. Antidepressants have been proposed to reduce the effects of long COVID-19. Antidepressant use has been associated with a reduced risk of intubation or death in acute COVID-19. So in this study, fluvoxamine, 100 milligrams twice daily for 10 days in high-risk outpatients have actually reduced the need for hospitalization, as you can see in this study. Low-dose naltrexone, approximately 4.5 milligrams either once or twice daily, has been used in centralized pain states to reduce microglial cell activation and inflammation in patients like fibromyalgia and CRPS, or complex regional pain syndrome. Whereas things have not been associated specifically or directly with long COVID-19, anecdotally in our pain clinic, we have had extremely good success using low-dose naltrexone in helping reduce the symptoms of brain fog and neuroinflammation that's very similar to fibromyalgia in these patients. There's a number of different treatment options that I'm giving you the national clinical trial status for. They're looking at things like hyperbaric oxygen and montelukast, dupirfenidone to treat the respiratory conditions with long COVID, breathing exercises. They're looking at an 8-week exercise program for long COVID-19 and fatigue. Vitamin C supplementation has been shown to be useful in treating fatigue in long COVID-19 patients. You can see the Lovett COVID trial here. IV high-dose vitamin C in hospitalized patients have been shown to be beneficial. They're looking at 2 trials for nicotinamide riboside, which is a dietary supplement that can potentially help improve cognitive symptoms and fatigue by modulating the pro-inflammatory response. And now they're also looking at probiotic supplementation to help recompose the gut microbiome and reduce inflammation in long COVID-19. To conclude, many patients have long ongoing issues from COVID-19 infection. Even 1 year out, the majority of patients will have at least one symptom, and it raises important issues for healthcare and research. And unfortunately, only 0.4% of patients with COVID-19 say that they participated in a professional rehabilitation program. It's unclear why this is. It may be poor recognition of long COVID and maybe a lack of clear referral pathways, but we need to recognize this more, especially as we're entering more of these patients to go into having surgery after COVID-19. And that's why it needs long-term investigation, especially patients with anxiety and depression, which continues at 6 months and 12 months, what this may pose in terms of potential issues associated with post-surgical complications and persistent post-surgical pain syndromes. And it's uncertainty. There's a lot of uncertainty about whether or not, from a public health perspective, we will be able to cover these things, at least in the United States, from an insurance coverage association. And of course, we need to be recognizing disparities in healthcare among different individuals. Thank you very much, and I appreciate the opportunity. I'm honored to be able to present this to your association. Thank you very much.